be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. Thank you all for coming, everyone in the room, everyone joining from online, either from the YouTube channel and or Facebook Live. Welcome, welcome. We're happy to have you. We're also very happy to have Dr. Jonathan Goldman from UCLA up to talk to us today about precision medicine, which is perfect timing. I'm going to read a little bit from an article that I read today, which speaks to the importance of education around precision medicine from a patient perspective as well as a physician perspective. So we're really excited to have everyone tonight. So I'm gonna turn it over to Dr. Goldman to introduce himself and tell us why he chose lung cancer as an area of specialty.
Great. Thank you very much. My name is Jonathan Goldman. I'm at UCLA. I direct the clinical trials and thoracic oncology program. I also I'm the associate director of the drug development program. And because lung cancer has been such a hot area of research, because so many drugs have been developed in lung cancer, it has been a remarkable place to have a career recently. I came, I think, 2 years ago or so, and I recognize some of the people, and it's really a tremendous thing that you've put together, and I'm just learning about the GO2 Foundation, but I am certainly reminded of why I do this, and it's wonderful to get to see everyone not rushed in not in a clinic, but sitting down together and spending a little more time. I trained here. I was at UCSF and Stanford, and so it's nice to come back to this area, which I definitely remember very fondly. When I decided to study cancer and lung cancer in particular, and you can see from what people said, this brings you very quickly face to face with very intense parts of life, and that was something that I felt able to be part of, and it was very meaningful. It immediately became very meaningful to me. Lung cancer, over a relatively short amount of time, went from a disease where many patients, doctors, family members, legislators were very, what we'd say, nihilistic about, that therapy didn't make a difference, that it wasn't clear that treatment was worth side effects, and that it sometimes wasn't even worth seeing an oncologist or discussing treatment options. And when you look at it that way, what a remarkable change has happened. It didn't used to be that you could talk in a room with people that were 3, 5, 6-year survivors, let alone 10 plus years. That's not that obviously to say we still have a lot of work. Yes.
At some point, and you don't have to do it now because maybe you need to do a little bit more to lead into it, but I'd like you to talk to patients tonight as well, because we're talking about precision medicine.
Yeah.
And, one's exon 14, one's exon 19, and then we got exon 20, and how important those submarkers are becoming.
So before we jump into that, because I do want to get into some of the specifics, I want to kind of step back even further. So for the folks online who might be really early in the diagnostic process, or those who might come back and watch later are in that early sort of space, can we step even back to the diagnosis and sort of what good looks like through that whole diagnostic process and biopsying and testing for these mutations that you're talking about? What is a mutation? Maybe even why do they happen, and why it's important to know what someone's mutation might be before determining a treatment.
Yeah. Well, I really love getting these questions, and it's always clear when a patient comes from you who really understands their cancer, and the stories that we heard are, I think, a great way to be a partner in the process, and to not feel pushed along by the process, but to be an active participant in it. So lung cancer particularly, many patients here talked about thinking they had asthma or allergies or something. Sometimes lung cancer diagnoses do take longer than you would want. And so at some point, a chest X-ray or a CT scan or a new symptom shows that there's a mass in the lung. A very important part of the next step is what we need a biopsy to prove what it is, and we need staging scans to see throughout the body where is the cancer at that point. The biopsies can either be done with a CT scan and a needle, or sometimes there are small surgeries that are done to get at lymph nodes, for example, or a bronchoscopy, where a lung doctor, a pulmonologist, will go down the lungs with a scope and grab a piece of the cancer. Then a pathologist will look at it under the microscope and say, these cells are clearly abnormal. They're not behaving the way they're supposed to be. They're not following the lines of usual cells. And in this case, they look like lung cancer cells. There are proteins that we can find on the surface that identify a cancer cell as a lung cancer cell. We might be able to say this is the most common kind, called adenocarcinoma, or maybe it's squamous cell. We didn't hear that much about another group called small cell lung cancer, but those would all be identifiable by the pathologist. The pathologist will also take, or hope to take, some of that biopsy and do what's called mutation testing. A lot of times that is through sequencing, meaning that you look at your DNA, or you look at the patient's DNA. DNA is on a strand, one letter after another, and they will use these laboratory techniques to rebuild that strand in a way that you can tell what was there. And we know what the normal is, and there are, in many ways, predictable ways that could become abnormal or mutated in a way that would promote cancer. It's a lot of words. It probably wouldn't hurt for me to say it again in a different way. But the DNA determines proteins in your body that create the normal function. And a mutation in the gene leads to a mutation in the protein that can turn the on and off switches of normal physiology, normal biology, to become wrong, to become dangerous, and sometimes that leads to cancer. We all, through our lifetimes, get mutations in our cells, and a lot of those mutations don't do anything. There are whole regions of our DNA that are not important, that just have like the detritus of evolution, but some of them come up in very important areas. The reason why there are certain common cancers, like common skin cancers or lung cancers lung cancer in smokers is that there are some exposures that cause extra mutations, like tobacco or the sun, the UV light and sun. And that can cause hundreds or thousands of mutations. And just, you can imagine by chance, if you're getting thousands of mutations, one of those or a group of those could lead to enough abnormality that that cell becomes cancerous. Most of the time, though, across cancer, we don't know why those mutations happen. It's just the cancer, the growth process, the cell growth process is so complicated and happens so many times that the chance of having an error becomes real over 50, 60, 80 years of life. Sometimes that is reassuring to patients. It's not that they did anything wrong, but that this can just happen. Sometimes it's also hard to know that some of this didn't happen for any reason. I think there are a lot of emotions that these events bring up. But what we do know is that this is an important part of the cancer process. I said that some of these mutations happen more commonly in Asian populations, and frankly, we don't know why. There are still some things that are yet to be understood. But through the late 1900s, people started to understand that an accumulation of mutations could cause cancer. And then really through the 1990s and this century, we really became focused on what are the most important ones of those mutations. What are the ones that are driving the cancer, be it breast cancer or be it stomach cancer or lung cancer. And really, lung cancer in a lot of ways has led the charge towards this type of treatment. I'd been using targeted treatment, but we can also use the word precision medicine, meaning that it's the right drug to the patient. And the sooner the better, and the better the drug, the better. But the basic concept of identifying what made this cancer cancerous ends up being very powerful in a lot of situations. I think we do have what we heard some of these sequences of responses and resistance, and response and resistance with new and better drugs. But we certainly have our eye on the possibility of can we do even better than that? There are a lot of different ways that we've learned to treat lung cancer. The standard older way is chemotherapy. And as we heard from some people, there really is still a role for chemotherapy. And actually, the only downside of all the new drugs that we have is sometimes people get so scared of chemotherapy that there is still a role for it. And sometimes it's actually clearly the best option. Mm-hmm. And in fact, our lung cancer chemotherapy, very thankfully, is effective for most patients and tolerable for most patients. So that is a good thing compared to some other cancer programs. We also have added to that immune therapy just in the last few years. And often immune therapy can be added to chemotherapy. We do talk about PD-L1, which was brought up as a marker, a predictor of benefit from immune therapy. But even aside from that, there are benefits to immune therapy. You can think of that as a targeted therapy. If a patient has high PD-L1, that directs them to an immunotherapy course. But what I'm going to talk about in targeted therapy is another type of treatment that is based on finding a mutation and treating that mutation. And maybe a third, if not more, of the patients here described EGFR mutations. And that's definitely the most common of these treatable mutations. It's about 10, 12% in this country. In Asia, interestingly, not entirely for clear reasons, is much more common, 30% or so. These mutations are more common in never smokers or minimal smokers. And in that situation, it can be 30 or 50% of the patients. And I think that's really what you might call the poster child of targeted therapy in lung cancer, really where we first saw some of these early drugs, Aresa or gefitinib, some might remember. And
it
then
was Tarceva.
And then Tarceva. Yeah, so they actually were used because EGFR was thought to be important in general. And in some patients, there was very little benefit, but in some patients, dramatic benefit. A patient with cancer throughout both lungs, they would be cleared. And it wasn't immediately obvious why. And then wonderful research identified that those tumors had a mutation in this gene called EGFR that was causing a growth protein that should be turned on and off at the right time to always be in an on position and cause constant cell growth, out of control, not functioning well with the rest of the body. In a pill with a small molecule in it that would block that mutation, turned that off. And it really opened up a world of targeted therapy in general, but especially for lung cancer. And increasingly over the years, about 15, 16 years now, we've been identifying new mutations. We think about the pie, pie chart of cancer patients, and we get more slices of the pie as we understand some of these mutations. We're a little bit better than 60% at finding what we call driving mutations in the most common kinds of lung cancer. And for many of those mutations, not all of them, but many of them, we're getting better and better drugs. So we talked about Tarceva, and now we have Tagrisso. For the next most common, called ALK, we started out with crizotinib, and now we have several new drugs. We've actually already on to fourth-generation drugs. And what do we mean by these new drugs? What's remarkable is that these drugs are more effective, less side effects, and excitingly better and better at treating some of the most difficult situations, such as cancer that's gone to the brain. So now instead of going to surgery or going to radiation, we're often seeing, can we treat with a pill? And so that can be quite remarkable, avoiding some of those side effects, or at least holding them off. Again, we still have this problem of drugs working for a while and then needing to look at new drugs, but some of these newer drugs are not working 10 months, but working 18 or 36 months, depending on the situation. So that's the way we've seen a lot of progress, by building new understandings. We heard about MET mutations. MET mutations were only described a few years ago. We actually reported the first time that crizotinib was used. And it was a patient who had not done well on 3 different kinds of chemotherapy. And she really was unsure whether to go on more treatment. And what we did was, at that point, not yet standard or not yet commonly done, but did an extensive mutation screen to look for, are there some mutations beyond the ones that we know about? And we found this MET mutation. At that point, very little was known, but we decided to try a MET inhibitor, crizotinib, and just as you're describing, really a dramatic response. Those stories don't happen all the time, but I think one of the ways I like to think about this is just, can we provide more and more options? A patient may have to try 2 or 3 possibilities, but can we get to something that may work particularly well? Just today, I saw a patient who, actually going on 6 years ago with EGFR mutation, started growing very, very quickly. Probably, in retrospect, she had something called a small cell transformation. We radiated that area, put her back on Tarceva, and then somewhat beyond our wildest, or absolutely beyond our wildest expectations, that has kept things under control for these many years. And you don't always know which of these different options is going to be perhaps the silver bullet for a patient. But by having more and more of them and learning, increasingly, what are our best ways to put this together, we hope to have these incremental improvements, and then occasionally we would like to have revolutionary improvements. There was a few other things I wanted to make sure that I focus on. One of them was just the importance of the mutation testing, particularly MET, because MET is a difficult one to test for, MET mutations. But in general, we heard several patients that were treated for a while before an EGFR mutation was found. We would like to have as much testing, as much identifying of mutations as early as possible. And that's one of the ways that patients really can improve their care, is by talking to their doctors about, have we done the testing that we need to do? Are there other things that we should consider now or in the future? There are so many different ways to test now. There's not a single solution for every patient, but we do have these broad tests that can test not just 3 to 5 genes, but hundreds of genes. And it may be that that's the direction that we're all moving. But it's certainly appropriate to ask those questions. One of the things that's made the biggest difference for me as a doctor is that we can now test a lot of these mutations in the blood, and we get the results in a week. It's just remarkable what that can mean for a patient that's either just had their diagnosis or has gotten very sick. And those are things that really we didn't see. We didn't even when that became available, we didn't realize what a revolution it was until it developed to be part of our practice.
So we get the biopsy, right? And quite often, as some of you know, and as one of my pet peeves, and I complain about it a lot, is the percentage of patients that actually go on to get this type of profiling, of the molecular profiling, right? And it's one of the things, and I'll get to it a little bit later, but it's about the article that I was reading today. And in academic centers where Dr. Goldman works, it's happening with the appropriate patients, right? Where it's not happening with the appropriate patients is in the community setting, right? Necessarily, not all community settings, but 80% of patients, as you guys know, I say it over and over and over, it sounds like a broken record to those of you who show up every month, but 80% of the patients are seen in the community setting. And a lot of a huge percentage of those patients are seen in very rural areas, right? Where there's a general oncologist who's treating whatever walks in the door. So, in my opinion, it's an unfair expectation that they would know everything there is to know, especially with how quickly things are happening today in cancer in general, lung cancer for sure, but in cancer in general, all this molecular profiling. And then, oh, we found an EGFR mutation. Well, now what do I do with that, right? Which is what happens a lot, which again is why it's so important for GoTo to be able to provide education services like this to you all and those watching, and to have these guys come in and talk. So why is it important that we find out what the molecular makeup is of each individual patient? What happens once we know that?
So there are some still legitimate questions about should we be testing everyone, sure, and at what point. So part of what makes it difficult is it's hard to make an across-the-board, sure, recommendation. But we do know that most lung cancer patients are diagnosed at stage 4. And most are adenocarcinoma, the plurality are adenocarcinoma. And in that situation, it's become clear that we do need at least the mutations tested that we have an approved drug for. We need those mutations tested. And I actually think that things are getting better faster and faster. But I don't know the whole country. Right. But I do think that as we get drugs to treat patients, and as doctors, it's also a joy for the doctors to be able to treat someone successfully with one of these new medications. As that happens, I do think that people are doing more and more testing. But I do think at some point a second opinion can be very helpful. Mm-hmm. You want to feel a connection with your doctor. You want to feel that they're hearing you, that they can explain things and why they're doing something, and that you have the room to ask questions.
be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.